So this talk is on cardiomyopathy, and we have about 30 minutes. I don't have anything to disclose relative to this talk. And I always like to start with this case, which is a real case that we had a number of years ago. A 65-year-old lady who came to us and came to the ICU after a femdistal for ischemic lower extremity. She started this episode of care at an outside hospital where she went because of some pain and difficulty with one of her lower extremities. And when she was seen there, they decided to put her on heparin. The leg got worse over a 6-hour period of time, so she got transferred. They did not have a lab that could invasively attempt to revascularize her lower extremity. And her discharge summary came and said that she had an echo which showed her ejection fraction of 20%. Her admit blood pressure at that hospital was 215/115. She went to the operating room where Swan-Ganz was placed, given this history of severe low ejection fraction. Her cardiac output, not index, her output was 2.0 when the Swan was placed. She got 500 cc's of fluid. Her cardiac output was 2.0. She got an epi-drip. Her cardiac output never passed 2.1. And she came to the ICU acidotic, lactemic, oliguric, and profoundly mottled. So that's the case. We'll come back to it at the end when you have some more information. But let's talk about congestive heart failure. And we'll start with what does it mean and what does it mean to you. So when you see that phrase, do you think cardiogenic pulmonary edema? Are you aware that some patients have pleural effusions and don't get pulmonary edema, and some patients get both? If it says it in the chart, do you continue it, whether there's any data to support it or not? And is it always an issue of that function is reduced? A question that I think now is starting to become less concerning and less confusing for people. Just a few background tidbits. About 50% of patients with congestive heart failure have preserved function. So it's not always about reduced function, even though that was the classic way we always thought of it. Your pump can't squeeze, fluid backs up, it backs up into the lungs, you have congestive heart failure. We know that the prevalence gets higher as you get older. We know that women tend to have it slightly more commonly than men. And because so much of it is preserved, that actually it is much more common to be asymptomatic than symptomatic. So one way to think about these sorts of patients would be to divide them up into categories like this. And I could keep going, but I'm not going to use this approach. We could talk about every single etiology. This is one of the 2 slides of all of the etiologies. We're not going to take that approach in 30 minutes. We're going to lump and divide them up into very simply whether they have preserved function or reduced function, what we used to call systolic or diastolic dysfunction. So that's how we're going to proceed. The question then is, does it make a difference? Can you just say the patient has congestive heart failure and you'll be okay with that? Well, this is a slide from 1999 looking at the almost 10-year survivability after the diagnosis is made. And you can see that systolic dysfunction or reduced function patient has a much lower survival than those who have diastolic dysfunction or preserved function. And so this has been the standard data. Now, Dare mentioned at the beginning, we do try to give you cutting edge information. So bear with me. I made this last night real quick. This is a slide out of a JAMA article from this week. And in this particular study by Lehrman et al. Done through the VA, they looked at patients with a variety of different diagnostic criteria relative to heart failure and looked at what the outcome is. So the first column I'll describe, or the first column I'll describe to you in just a second, and it's going to break down into 3 rows, the top 2, the middle section, and then the bottom 3. And the second column is mortality rate, and the last column is the adjusted absolute risk change. So we're going to look at a variety of different issues here. So let's start at the top. Without heart failure versus with failure, their diagnosis or definition of heart failure was that you had at least one admission into a VA in which the ICD-9 for heart failure or one of the ICD-9s for 10 for heart failure were used, or you had 2 clinic visits in which somebody coded you that way, and they've done work that they quoted that showed high sensitivity and high specificity for that coding system in the VA system. And you can see that the mortality rate, if you did not have a history of heart failure by coding, was 1.22, and if you did have a history, then it looks like your mortality went up about 4-fold or 5-fold, depending upon how you do that math. What's interesting is that when they looked at whether having a history of heart failure or not was a predictor of outcome, you can see that there's a slight elevation, 1.03 in the adjusted risk, but that the confidence intervals cross 1. So that in fact, it was not a predictor of outcome, just having this history by diagnostic code of heart failure, and that what the interpretation is, heart failure has comorbidities, and the comorbidities are driving the mortality, not the heart failure, at least defined by coding, okay? The middle section of this table from this recent article. Again, the first line, the first row in that middle section is that group without heart failure. Now this is looking at their function by echo, and you have a group that had preserved, and then you had a group that had progressive declines in ejection fraction that were listed. And you see what many people would predict, which is that mortality goes up. But notice again the disconnect between the mortality change that happens and the risk of those things happening. And where the risk comes in is when you have reduced function, what we would now call HFrEF, heart failure reduced ejection fraction. So if you have that and you have an EF of 40% or below, 39% or below, then what you see is that now you have an increased risk of death in the perioperative period. And then finally, in the bottom down here, what they did was they look at symptoms, and their definition of symptoms are listed in the paper and include things like shortness of breath and RALS and JVD, et cetera. But if you had that documented within 30 days, you were considered symptomatic. If you didn't have it in the last 30 days, you were considered asymptomatic. And again, you can see, as you might predict, that if you had symptomatic signs of heart failure in the 30 days perioperatively, then you had an increased mortality in that perioperative period. Complex study. You'll notice several things there look like you had decreased risk. Hard to explain how a patient with diastolic dysfunction, the preserved function called HFpEF, heart failure, preserved ejection fraction, had a benefit by having that disorder in the perioperative period, or that if you had a history of heart failure but were now asymptomatic, that your odds ratio over there was 0.74. Hard to explain some of those variables, so more work is clearly needed, but we wanted to make sure you had this cutting edge info from an article this week in JAMA. So you would think that if you could predict which population, just by looking at them clinically or thinking about them clinically, you would say, well, patients coming for vascular surgery probably have perioperative or have had multiple ischemic risk relative to their cardiovascular risk. Because of that, they're more likely to have systolic dysfunction or reduced function, and so I'll just treat them that way. Well, this study decided to take 325 patients going for elective surgery and echo them, and found that actually the more common diagnosis in this population was diastolic dysfunction. The most common postoperative complication was clinical evidence of congestive heart failure, and that the diastolic dysfunction was more predictive than the systolic dysfunction that happened. So you can't just think about them clinically and say, well, they have ischemic burden, so they're going to have systolic dysfunction. You're going to need to think about acquiring additional information. And as I've said multiple times now, this is how I'm going to divide them for the rest of the talk. And the more common phraseology, again, in today's world is HFrEF and HFpEF. So we're going to go back to basic physiology. This is a volume pressure curve. I hand drew it. You can tell I'm not an artist. That's what you've learned so far. Down here at the very bottom is where the mitral valve opens. Let's say this is the left ventricle. Then across the bottom, you're going to have diastolic filling. You're going to have isovolumetric contraction. And then at that top corner, you're going to have the aortic valve open. You're going to have ejection across the top, and then isovolumetric relaxation that occurs. And this continues repetitively, right? So if you think about it, this is where the ventricle is filled. So this is the same as the end diastolic volume. After ejection, this is the blood that's left in the ventricle, so the end systolic volume. And the middle of the curve is the stroke volume, right? So EDV minus ESV is stroke volume. And the ejection fraction is how much you eject, your stroke volume, over what the starting size, the starting diastolic volume was. In fact, the most common cause of EF being low is actually not that the stroke volume is impaired, but that the denominator is large, right? Given repetitive volume overload of the heart or other conditions that produce that disorder, what happens? The ventricle dilates as a way of making it that the stroke volume is going to stay protected, and we'll come back to that a couple of times. So let's think about this hypothetical case for a second. 75-year-old man, echo shows an EF of 15%. You put in a pulmonary artery catheter, and the cardiac output is 7. Is this possible? And the first answer many people will say is, as well, let's see here, cardiac output is stroke volume times heart rate, so this must be tachycardia. Well, unfortunately, right, the more tachycardic you are, the less time there is in diastole. And if you have less time in diastole, then you have less filling of the ventricle, so you compromise stroke volume. So mathematically, it's a wonderful thing to say heart rate, but clinically very difficult to do. So the answer here really is a better understanding of what EF is versus cardiac output. Here it is mathematically. Let me show you it this way, right? A 50% of a small ventricle is the same total ejected volume as 30% of a large ventricle. So that's what you have to keep in mind, that your organs are worried about what your flow is, and your organs are worried about what your perfusion pressure is. The ejection fraction, although a easily obtained and very interesting phenomena, and may very well turn out to have some clinical prediction, I showed you that recent study from JAMA, is actually too often confused with cardiac output and flow, and your organs care about your flow, not your EF. Okay? So remember that cardiac output and EF not the same. So let's focus at the preserved function, the one that's a little harder to understand. At least historically, we didn't understand as much about it. Where would that curve be if the ventricle was hypertrophied, okay? So your choice in your, to think to yourself is, could it be to the right, could it be to the left, could it be up, or could it be down? And the curve would be where? To the left and up. And that's important, that it's both left and up. That means that small volumes equal very profound changes in pressure. Small little shifts in volume are very high changes in pressure, okay? Because the ventricle is stiff. It can't relax, and it may have some compliance issues. It's under a lot of tension as well, okay? So is this real, or is this just a made-up condition? Here's a study that took patients to the cath lab. You can see that the end diastolic volume difference between those who had diastolic dysfunction and those who didn't was about 10 cc's. It's about a 10% difference, but about 10 cc's. Think about that. But the minimum ventricular pressure and the end diastolic pressure was threefold higher. So 10 fewer cc's, but 3 times the pressure. If you put in a Swan-Ganz, you'd be getting those sorts of end diastolic pressures that you would have to know about. So very real thing that the ventricle can become, over time, many times secondary to pressure overload chronically, very non-compliant, okay? It has both difficulty in compliance, and it has a difficulty in relaxation as well. So I sort of, not to make fun of these individuals, but try to joke that this is what you have to think about the heart is looking like when it has HFpEF, right? It's a big stiff ventricle for which the arms can't relax, and they're under constant tension. So it's a relaxation problem and a tension, a compliance problem at the same time. And there are multiple grades of HFpEF. And start at relaxation as a problem, and the higher you get from grade 1 through grade 4, then the more you have worsening of the relaxation problem, and you have a start of the compliance problem as well. So how can you diagnose diastolic dysfunction? There's a variety of ways. Is there a heave? Maybe they have hypertrophy on EKG. In the old days, you might get a MUGO or resting gated heart scan. For all practical purposes, echo is the test today. For a long time, cardiologists had multiple different ways that they might hint at this. They might just say LV hypertrophy, they might say concentric LVH or cavity obliteration. We then started to understand, and we came up with some criteria. The first ones were the volume criteria the velocity criteria of 0.45 meters per second. We learned over time that there were better markers, and on the very bottom of the slide you see capital E to E prime. This is where you get an echo and you can measure the relaxation of the muscle that's perivalvular and the valvular tissue as well. You can calculate an E to E prime, and the larger that number is, the worse the diastolic dysfunction is. And so that has become the test of choice now and the diagnosis of choice. I wanted to explain what E to A change is for those who remain unclear. So the atria empties both passively and